Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
Hi, I'm Steve Karstensen, and today we're going to talk about some of the connections that you may see in your practice or you may have not seen in your practice, and I might be able to give you some insight into how some of your patients are giving you some troubles. You're scratching your head, you're wondering why they're not getting better. Maybe there's a reason for that. Let's talk about the connection between TMD issues and maybe some sleep and breathing issues. There's a concept called functional somatic syndrome. Many of our patients have come to us with a history. They say that they have fibromyalgia. They say they have some other widespread pain syndromes. They've been to a lot of doctors. They've tried a lot of different medications, but nothing seems to work. When they talk to their physicians, they're given the term medically unexplained. We don't really know what's going on with that. And on that list is temporomandibular disorders, the thing that we take care of, that none of the physicians take care of, but they're still in our office with the same complaints. So a body physiology process is called homeostasis. It's a system set up in our brains and our bodies to maintain normal health through a bunch of different challenges to our everyday living. Allostasis is the process that returns us to normal, so we can respond to different challenges that happen to us. And some of those challenges are normal, like going to the gym and getting all hot and sweaty. Well, that's fine. It's okay to get hot because there's a mechanism to return to normal. That's sweating. In this case, we can also have other challenges, emotional challenges, psychosocial challenges, lots of things that can happen to bring us out of homeostasis. But because we have an allostatic process, we return to normal. The concept looks like this. There's a challenge, there's a response, and there's a reset back to normal. So in this case, for example, we have exercise overheating, we have a response by sweating, and we have a return to normal. This is the acute allostatic challenge, so some short-term, sudden kind of a thing. There can be a chronic allostatic challenge, however, and can be good and it can be troublesome. The challenge happens, we have an adaptation response. So our bodies change in some ways. We can call that conditioning. For example, if we wanted to learn a new sport, we go and we challenge our muscles to move our bodies a certain way, and they respond by getting more flexible, different neurologic controls, stronger, longer, whatever happens to change our bodies to allow a chronic allostatic challenge to become normal. Because again, returning to homeostasis. If we are able to overcome these acute challenges, manage our chronic challenges, and change our homeostatic baseline, then our bodies are normal. That's what's supposed to happen. There, however, can be these other things that are more troublesome called perpetuating allostatic challenges. So in our example we're going to talk about today, upper airway resistance syndrome, which is a narrowing of the airway, and I'll talk about that more in just a second. That activates our body in different ways, different kinds of response, different parts of the allostatic response. And it ends up with this functional somatic syndrome. So how does this happen? Well, an acute allostatic challenge creates a response. We've talked about the reset, we've talked about conditioning. When we have a perpetuating allostatic challenge, however, that can sensitize part of our brain. The part of our brain it works on is the limbic system. So a challenge to our bodies that causes a sensitization changes the baseline of response, which is different than homeostasis, different than even conditioning. So what's the mechanism here? The mechanism here is, I think, fascinating. We think about cranial nerve 1, the olfactory nerve. When we breathe in odorants, which are the little particles of things that are floating around, attached to these the nerve centrals, and that sends signals to our cortex and tells us what we're breathing, tells us what we're able to detect in the air. Those electrical signals goes directly to the cortex. That's kind of different for a cranial nerve, by the way. The other properties of cranial nerve 1, however, are fascinating. There turns out to be mechanoreceptors in this olfactory bulb. They didn't know this for a long time. That sends pulses not to the cortex, but to the limbic system. And those mechanoreceptors measure air pressure changes. Now, why is this important to us? The limbic system regulates emotion, the autonomic nervous system response, and lots of endocrine systems. There's a lot of things happening in the middle part of the brain with the limbic system. And sleep-related breathing disorders such as upper airway resistance syndrome, obstructive sleep apnea, we cause some differences in the pressures of the airway. We have increased airflow, sometimes lower pressure through the nose as the body tries to struggle to get air through a smaller space. And it can trigger this limbic system to become upregulated, a chronic or perpetuating allostatic challenge to that portion of the brain. Why is this different than obstructive sleep apnea syndrome? Well, if we think about the airway back there and we have a closure of the airway and we have a negative pressure inside that closure, so where the lungs are expanding, so the trachea and others will have a negative pressure zone. When we have a slightly open airway, like upper airway resistance syndrome, we can still move air through that. We still have that negative pressure below that obstruction point, but what's different is what's happening in the nasal airway. Because in the nasal airway, with the air already open through the back of the throat, we have a negative pressure zone there too. If we completely close the airway, then we have a normal pressure in that nasal airway. And that normal pressure doesn't trigger signals to the limbic system. The negative pressure does. So we can have an upper airway resistance syndrome with sustained narrowing of the pharynx. And so we get a negative pressure there frequently. And it can happen over a long period of time. Obstructive sleep apnea doesn't change the pressure in the nose, so it doesn't affect cranial nerve 1, and it's very short term. We don't live very long with a closed off airway. So the upper airway is the sustained portion. So we get that chronic signals to the limbic system. High airflow sends repeated signals to that part of the brain that can respond with a sensitization. Sensitization perpetuates that allostatic challenge. We get that limbic system up regulation. So we end up with this functional somatic syndrome, a chronically irritated hypothalamic regulation. What does that mean? That means we can disturb how breathing goes through the nighttime. It can disturb how the very basics of our sleep cycles go. It can disturb our cortisol levels. Now, the HPA axis is something we hear a lot about because it's so fundamental to our physiology, and lots of things can disrupt this. We're not going to talk about that in this short time, but cortisol is part of this, and we know that cortisol is important for us. We need a lot of cortisol to start our day, but we're not supposed to have a lot of cortisol going on through the normal day. When we have a upregulated limbic system, then we'll have a lot more cortisol happening because we don't have that limbic system cutting it down. In fact, we have stimulus to that HPA axis, creating more problems. So one of the things to think about when you compare your obstructive sleep apnea patients coming in, the OSA patients might be sleepy. They're complaining of snoring. They're complaining of being tired in the daytime. Your upper airway resistance patients, however, according to this study, tend to have more neurotic and sensitive personalities. That upregulation of the limbic system also disrupts their emotional centers. So the patients are different than the ones that have OSA. You start to think about the people you're seeing and the ones that are coming in and they're saying, wow, you know, I'm nervous, or I'm anxious, or I'm more sensitive to pain. They're complaining more about pain. Why do many dentists stay away from treating TMD patients? Maybe because we could actually classify TMD patients the same way, tending to have more neurotic and sensitive personalities. Those patients are challenging to deal with. But one of the reasons why they're challenging is because we may not be getting to the reason why they're neurotic and sensitive in the first place. So what can you do with this? Well, first of all, you can deepen your health history. In other words, ask more questions. You have to find out what's going on with their sleep and breathing. And it may not be traditional. It may not be something where they've gone to the physician and said, well, I'm having these troubles. And the physician says, oh, well, you must have a breathing problem. In fact, many of the patients that come see us for this problem have been told they have no breathing problems. That's a different challenge. And it's going to be something that dentists can have a lot to do with. But it takes new systems in your office. It takes attention and follow-up to these patients. You have to know what to do with them, you have to do something about it, and you have to follow up because it may not be the first treatment that is totally successful. You also have to expand your scope a little bit, scope of your practice. You have to learn more things. You have to be able to handle many of the patient's complaints and put the puzzle together. This can be very challenging, but it's also very rewarding when you get somebody with a functional somatic syndrome that's been told they have no explanation medically for why they feel the way they feel. You ask them some questions about sleep, uncover a chronic breathing problem, give them a solution, and all of a sudden they feel tons better. I mean, dramatically better, quality of life better. And that's going to be a big reward for your practice. So why do some patients have more trouble than others? Because they haven't been listened to well enough. That's what you can do. Go back, listen to your patients, develop new systems for uncovering these patients, and you'll have tremendous rewards coming for your practice. I'm Steve Carstensen, and I'm glad you were able to watch this video today.